Cresswell here. I'm one of the movement disorder neurologists at the Pacific Parkinson's Research Center in Vancouver. I'll be telling you a little bit about how young onset Parkinson's is different from people with older onset Parkinson's. That essentially assumes that you already have a bit of a basic knowledge of what kind of symptoms Parkinson's can come with. If you have any questions that would go back to more what kind of symptoms can I generally expect, then obviously ask those questions. I'll be very happy to answer those. And from what I understand, really the presentation and the slides should just be the kickoff to have a conversation and to be able to ask questions. So with that, I'll get started. So what we're going to look at today are a few questions. So first of all, as mentioned, we'll look at how young onset Parkinson's, YOPD, is different from Parkinson's disease that develops at older age. Then we look at the always really important question, when to start treatment. The question whether one can predict future progression with a young onset PD, and how it can affect family, social, and work life. Last but not least, and that was also addressed in the last 2 weeks a little bit already, is what are some strategies to help you and your families deal with young onset Parkinson's. So how is it different from Parkinson's at older age? So there are some important differences, and they pertain both to the type of symptoms that are experienced by most people, as well as how fast the underlying condition progresses. So usually, and this has been really replicated in many studies, people with younger onset Parkinson's, and depending on the study you look at, that might be under the age of 40 or under the age of 50, sometimes even up to 55 as age of onset. So people with younger onset Parkinson's usually experience a slower disease progression. I'll come back to that as well. There is the drawback of having motor fluctuations earlier, but they do live longer with their condition. What is really important to note is that Parkinson's is very individually different. It is not the same condition for everybody. There are vast differences, and it is really unique to you, and comparing oneself with the next person and the treatment of the next person is generally not all that helpful. And you might have seen in assessments as well that we really very much try to understand the details of what it means to you and how it affects you, and then tailor that treatment plan to the issues that arise. Generally, it is a bit difficult to estimate for an individual how quickly or slowly Parkinson's will progress, but there are a few hints, and as mentioned, I will come back to that. In the slide before, I mentioned motor fluctuations. So the first question, of course, is what are motor fluctuations? And that is actually a very important concept to understand. That is something that we talk about in the clinic a lot, because it very much determines on how we're using the medication, at what dose, at what exact timing, how we're trying to keep it apart from protein-containing food, etc., how we are designing it around your workday, you have very active times, exercise times, etc. So motor fluctuations refer to the problem that the effect of the medication, of the dopaminergic medication, might not be the same all around the clock. So there will be, towards the end of a dose, there can be some wearing off and return of symptoms, and the art is to time your dosages in a way that the return of symptoms doesn't really become a problem. Early on, we can often achieve coverage of the entire 24-hour day. That might become a little bit more difficult later on, but there are different strategies to deal with that. But wearing off means that there's return of symptoms towards the end of a dose. That also implies that these symptoms have been successfully treated before because they've improved, and that is why you then realize that they're coming back. And importantly, that can be those can be symptoms that are from the motor domain. So that could be, for example, a tremor coming back, or that could be stiffness or slowness coming back. But for many people, the first thing they notice might be from the non-motor domain. So that might be, for example, feeling anxious, or just feeling just cloudy in your head and just not being able to think as quickly as you would when the medication is working well. It can be being anxious. Other people start to sweat. It could be having to go to the washroom to pass urine urgently. So there are different symptoms that can be present, and it's really important to recognize that. And then also, before you come to the clinic, to have a little bit of an idea what the usual patterns around the day are. So this is end of dose wearing off. And then there are unpredictable offs. That is usually more of a problem really later on, where we cannot really follow that usual pattern where a medication dose kicks in and then wears off, and then the next dose kicks in again, but it might be appearing a bit more random that there are offs. Freezing of gait, that is actually more of a problem in either advanced or older onset Parkinson's, but it can happen in younger onset Parkinson's as well. And then again, this is really much more of an advanced problem, would be a failure of a dose to kick in at all. Now, dyskinesias, they're also a way of motor fluctuations, because dyskinesias have these involuntary additional movements. They look a little bit random, and you probably all have seen those and are familiar with that. And they occur more frequently and earlier in younger patients with Parkinson's. On the upside, younger patients are also usually more responsive to the benefits of dopaminergic medication, but they can experience these dyskinetic side effects more often than older people. Now, when we talk about dyskinesias, again, this actually includes several different kinds of dyskinesias. So the most important one, and the one that most people are familiar with, are peak dose dyskinesias. They usually occur when dopamine levels are high. So let's say somebody has taken the medication and the medication kicks in, let's say 30 minutes later, and an hour after taking the medication, there are lots of extra movements that affect the entire body, often the arms, the trunk, the head as well. And those are typically peak dose dyskinesias. They are present when the medication is otherwise working well. So when stiffness and slowness and tremor are actually well reduced and controlled, then like an overshoot, you essentially go overboard and you have too many movements. And those are the most classic ones that we encounter. It is very important, though, to know that there are other kinds of dyskinesias as well. And the reason why it is important to understand that there are different kinds of dyskinesias is that that the treatment for them is the exact opposite to what we would do when somebody has peak dose dyskinesias. And one of those two other types of dyskinesias are what we call biphasic dyskinesias. They occur when dopamine levels are comparatively low. So when the medication is just kicking in, so when somebody is just switching on, or towards the end of a dose when they're switching off. They usually affect the legs more than the upper body, and they come with increased rigidity when it's at the end of a dose and return of tremor, or just at the switching on if it's early in the dose. Generally speaking, dopamine levels are too low and need to be increased. So the exact opposite of what we would do if somebody has peak dose dyskinesias. And then there's off dystonia, and that happens when in off times. So for example, very classically, upon waking in the morning, somebody hasn't had any dopaminergic medication all night, now dopamine levels are low in the morning, and then one could wake up early in the morning with a foot that is turning in and a cramping sensation, and that can be quite painful, or the toes can curl down. And that again occurs when dopamine levels are low, so again, the treatment for that would be to increase dopamine levels. Now, peak dose dyskinesias have been the subject of many discussions, many papers, and are probably one of the topics that I discuss the most with particularly young onset Parkinson's individuals. And what they are due to are a combination of the underlying Parkinson's process that is really important to understand, as well as the medication. They are much more likely to occur with levodopa compared to, for example, dopamine agonists. But what is really driving those peak dose dyskinesias are the duration of Parkinson's symptoms, so the time since Parkinson's onset. So a longer duration of Parkinson's symptoms, which is in turn associated with more severe dopamine cell loss, because that is what happens in Parkinson's as the underlying problem, or one of the underlying problems, will make peak dose dyskinesias much more likely. Now, as mentioned, those with young onset Parkinson's disease often and very usually have much longer disease duration over time, but they also seem to have more severe dopamine cell loss. And this might be one of the reasons why they are more susceptible to these peak dose dyskinesias. And then what drives it from the medication side is levodopa, and particularly high dosages and spikes in levodopa. So what we're trying to do is to keep the levels of levodopa as even as we can, and that is what we have as a physiological condition in the brain. So dopamine levels should be as even as possible, and that is what it is in a healthy brain. And we're trying to avoid these peaks and troughs. Now, another very important bit to know about peak dose dyskinesias is that although the majority of young onset Parkinson's patients might develop peak dose dyskinesias over time, these dyskinesias are often mild and do not have an impact on quality of life in studies that have looked specifically at that. But there is a smaller subgroup that can develop severe dyskinesias, and in that case we try to adjust the medication, and if that is not successful or is not effective enough, then things like deep brain stimulation can be looked at. And deep brain stimulation is really one of the interventions that we have that is particularly suitable for young onset Parkinson's patients, because usually those individuals are medically much fitter and will be much more able to benefit from deep brain stimulation. The important bit to know about peak dose dyskinesias is, and these peak dose dyskinesias have really driven this concept of levodopa phobia, is that saving medication for later, which is a concept that seems to be floating around the internet a lot still, and very unfortunately that it is still floating around. So saving medication for later is really an outdated concept, and it does not prevent dyskinesias and does not improve function neither now nor later. And that is really important to know. So I think many people are very stoic, saying, well, if I don't start medication and I just try to be as tough as I can, then I will have a better time later. And it is unfortunately not like that. It is actually exactly the opposite. If you treat and then are active, and I'll come back to that, quality of life and function will be much better down the line. Changing topic slightly, balance problems are often less likely in young onset Parkinson's. They can still occur, and obviously if that is the case, and particularly if that is interfering with your line of work, or if there's risk of falling, then obviously speak to your team. But fortunately they are generally less likely to occur. Similarly, cognitive changes, so problems with memory, with decision making, with speed of thought, concentration, etc., are less likely to occur in young onset Parkinson's, and there's a lower risk of developing dementia. but there might be some milder cognitive changes that are relevant, and it depends then very much on your line of work. So a pilot or an air traffic controller or somebody else who has to really have excellent attention over hours on end would be certainly much more affected than somebody who does not need to do that in their occupation. Also important to know that some medications, and this is particularly true for the dopamine agonist, can also influence our decision making and can lead to more risky decision making. So if somebody, for example, is a stockbroker or a financial advisor or a surgeon or a judge or whatever else you can think of, making more risky decisions could have quite important implications. Now, depression and anxiety, that really is a very, very important one, and one that we address in the clinic over and over again. Particularly younger onset Parkinson's often comes with a greater risk of developing mood changes, and that is both anxiety as well as depression. Some of that might certainly be in response to the situation, to having a chronic condition with certainly effects on social life, on work, on family, etc. But very, very frequently, it actually is part, like a chemical imbalance, of the underlying Parkinson's itself. So often we actually see the development of depression and anxiety before any diagnosis of Parkinson's is being made, before even any motor symptoms are present, because it is an inherent part of Parkinson's itself and is due to chemical imbalances. What is really important and often not talked about, it is not a sign of weakness, and it is part of Parkinson's and it can be treated. So really important to actually talk about that and to accept that this is something that we can address. So talk to your team, talk to your family, and then we can address that. Important topic, when should I start treatment? Now, treatment was of course discussed last week, and I'm not going to go into the details of that again. But because it is such an important topic in the clinic, I would like to say the following. The goal of treatment is to keep you as active as possible, and also to replicate what happens in the brain when there is no Parkinson's. That all our brains have dopamine in them. We need it for motor function, so for movements, we need it for thinking, we need it for attention, we need it for many other things. We also need it for reward, so that we can experience reward when something positive happens. And particularly the part of the brain that deals with motor function has a lack of dopamine. So what we do with the various medications, be that dopamine agonists or be that levodopa itself or any of the dopamine enhancing medications such as entacapone or sertraline, we try to increase the level of dopamine, particularly in the motor part of the brain, but also in the other parts. And that replicates, that tries to mimic with that replacement therapy like insulin for diabetes, that tries to mimic the normal physiological conditions in the brain where we have steady dopamine levels. So trying to replace the dopamine by giving levodopa, which then becomes dopamine in the brain, is really trying to make the brain work as closely to its usual function as possible, because when it has enough dopamine, it is the most effective. It can work around, it is very, very plastic, and it's trying to compensate left, right, and center, and it's trying to work around this roadblock, but this will never be quite as effective and as efficient as actually having the dopamine on board. It's like the fuel that you need to have the brain work well. So when should treatment be started? It really should be started as soon as Parkinson's symptoms start to interfere either with your usual activities or, and that I think is really important, with the ability to exercise. And why that is, we'll come back to that later on. So if there are any problems with doing the level of exercise that you're used to or any of your work, this is really the moment to look at medication. Nobody gets a medal for hanging in there and trying to be as stoic as possible, and many patients are very, very brave, and they say, you know, I can deal with that and I can do without the medication. But studies have shown over and over again now, and these are all the newer studies as well that have shown this very clearly, that people who stay active and are being helped by the medication to stay active definitely do better in the medium and long term as well. Now, how can young onset Parkinson's affect my family, social and work life? Now, I'm sure all of you could tell a tale about what has been happening, and so I'll touch on some of these issues. Elaine Booker, our social worker, I think went into this in some more detail, and of course she's the expert for that as well. So it can for sure affect marriages, and it can lead to financial challenges. And indeed, people who have got YOPD are more likely to have marriage and employment difficulties. And not surprisingly, there might be early retirement or long-term disability at some stage. Having said that, many people with young onset Parkinson's also continue to work either full-time, and I certainly have quite a few patients who continue to work full-time or in a part-time capacity. But often, certainly, the income can be reduced, and if the breadwinner of the family has YOPD, then the family budget might certainly be quite affected. And work, of course, is not only important in terms of finances, but our careers and the employment have many other functions for us as well, be that the social function, be that feeling of self-esteem and identification, in addition to those finances, to those financial questions. And so, if somebody is thinking about leaving work or reducing work, there are many, many factors that play a role. And some factors that we look at when discussing those decisions are how severe are the symptoms, which of those symptoms are particularly limiting in the ability to stay in the workplace, in this particular workplace, how much support is there in the workplace, could certain tasks maybe be delegated or not, how precise do hand movements have to be, so somebody who works as a dentist or a watchmaker or and has to have, you know, the artist would probably be more affected by fine motor difficulties than somebody who does not have to do these things. How much manual labor and how much shift work is involved. Shift work keeps coming up as an issue, and I'm always very happy to write letters for our patients to say that we very strongly recommend for people not to do shift work, because sleep is often disrupted anyway. Sleep is really, really important, and shift work certainly not helping in that regard. Having a regular schedule is actually very important. There are safety issues, building sites, driving, etc. Levels of fatigue can play a big role. And then there are, of course, all the questions regarding benefits, including medication cost coverage. So, for example, whether somebody has third-party insurance that work, any other extended benefit plans. Sexual and reproductive health. Those are topics that are very much a topic, I'd say, at home, but are often not really addressed well in the clinic. If that is the case, and if you have any concerns, definitely raise them with your physician or with your nurse. This can very often be addressed, and it is important to, first and foremost, of course, talk to your partner as well. So communication is really, really key. Often the person who has the young onset Parkinson's is taking a bit of a hit in self-esteem as well. There are other examples where people are just really, really good in dealing with all of that, and they're making it their own strength, but many people also struggle with that new concept. And that often has an effect on sexual attractiveness in their own mind, and the partner, of course, will also have to adjust to that new situation. The really important bit here is to talk to your partner and to have communication of what preferences are, where difficulties are, what makes each one feel relaxed, etc. As mentioned, it's not always part of the routine neurological examination and conversation we have, but definitely raise it, because there are many things that can be done, be that counseling, be that using certain props, changing positions, a referral to the BC Sexual Health Clinic, and they are really superb there. Changes in medication schedule or dosing. Antidepressant treatments can often, unfortunately, have an adverse effect on sexual appetite as well as erectile dysfunction. So raise it if it is a concern, and don't feel shy. Now, coming back to predicting the future progression. So as mentioned, it is really different from person to person. No two people are the same, and I just cannot say this loud enough. First of all, how do you know that Parkinson's is actually progressing? So sometimes you just feel that things take a little bit longer than they're used to, getting dressed, eating, etc. It might be that symptoms that were on one side of the body then affect the other side as well. There might be changes in walking, with walking getting slower, or posture being a little bit more stooped. Sometimes symptoms are worse one day and then not the other day. And everybody can have an off day. Being very nervous or stressed can certainly make symptoms worse. Having had a terrible night of sleep will certainly make things worse, or being sick otherwise, let's say with a flu-like illness or so. That certainly happens. If those days happen very frequently without any other cause for that, then that might also be a reflection of progression. And you might notice that you feel that your medication is just running out or not as powerful as it used to be, and it might have to be adjusted. So those are things to just keep in mind, and without watching yourself constantly when you do speak to your doctor or your nurses, it's important that you mention those things. Now, the always important question, how long will I live with Parkinson's? So this is, of course, again, very different from person to person, but it depends very much on the age of onset, how symptoms are being managed, the Parkinson's itself, and then general health issues as well. And nowadays, I think one could actually also add how much exercise you do. This is very likely to have a positive effect here. As people get older, as we all get older, and as the underlying Parkinson progresses, there will certainly be increased risks. And the two main ones really are falls, so the impaired balance, but this is really very much advanced problems often, or swallowing problems, which can then lead to pneumonia if it isn't recognized early on. But as mentioned before, patients who have young onset Parkinson's disease generally live much longer after a diagnosis of Parkinson's disease than somebody who's got older onset. And as mentioned, it really is different from person to person. Symptoms are different, progression is different, and there's not much point in comparing oneself to the next person. Now, what are some strategies to help you and your family deal with the young onset Parkinson's? So I think that the first step you're already taking, anybody who is here, is for sure trying to learn as much as they can about Parkinson's. And that, I think, is really, really key. The more you know about it and the more proactive you are about it without it letting it preoccupy your mind the whole time, because you're so much more than this diagnosis. You're living with it, but you're not the diagnosis. So learn as much as you can about Parkinson's, because that also helps you to recognize what is going on. It helps you to very effectively speak to your healthcare team, and together we can then tailor treatment and interventions. It is often very useful to reduce stress in your life. Some people do that by doing yoga or Tai Chi or meditation. Exercise is certainly really, really helpful. Humor is always great. And talking about exercise, the most important bit, other than actually doing it, not just having the stationary bike in the basement, but actually using it, is to find an exercise that you really enjoy. So stay as active as you can. If you can do it in a group, even better, and maintain a positive attitude with it. Other people, and there'll be a whole session dedicated to exercise next week, so I won't talk too much about it, but I cannot say clear enough how important exercise is for living well, with or without Parkinson's, but particularly when Parkinson's is there. And the patients in my clinic who take this to heart and really make exercise their new part-time job, they definitely do so much better. And that is supported by studies as well. Many creative activities, be that painting, singing, dancing, playing an instrument, writing poetry, can also be very helpful. And very importantly, we always say Parkinson's is a family affair, so care partners need to look after themselves as well. They need to learn, or should learn, as much about Parkinson's as possible, because that will help everybody in the family. But they also need to really take care of themselves. So definitely continue to have their own interests and to go out and take time to relax. Try to have as healthy a lifestyle as possible, including exercise. Again, if you can do it together, even better. Good nutrition, and don't be shy to use services. We always say it takes a village to raise a kid, and this is the same here. A team approach is really so much better in the long run, and more satisfying, and it will make you just also maintain a different attitude and energy level. It's a good idea to have an emergency plan in case you're not around, or if you become ill, and again, have a support network. And with that, we're opening to questions and comments.